Respected Chair, friends, I'll show this case of 65 years old male diabetic on insulin, hypertension for last 25 years. He underwent a coronary artery bypass grafting 15 years ago and chronic kidney disease 2 years and presented with florid heart failure. You can see the massively elevated jugular venous pressure and multiple admissions in last 3 months. His EGFR is 29, urine albumin creatinine ratio is 785, NT-proBNP is 3800. He's on insulin, empagliflozin, telmisartan, torsemide and bisoprolol. How to go about with this patient? We have almost exhausted our armamentarium. The patient is coming back, and when you see the echocardiography, the heart is contracting extremely well. You can see it's extremely well contracting heart. So this is heart failure and a preserved ejection fraction. Multiple comorbidities, which is the rule in heart failure and preserved ejection fraction, and extremely difficult to manage. The heart failure, which is highly prevalent, and of the total heart failures, more than 55% belongs to the group of ejection fraction more than or equal to 40%. But at the same time, though the ejection fraction is high, the outcomes are not different. The outcome is same, and this incidence worldwide is increasing. There is a 23% increase from 1994 to 2014, and this is an ongoing phenomenon. More number of heart failure with preserved ejection fraction because we are detecting more, and more number with heart failure and mildly reduced ejection fraction, partly due to the best treatment of heart failure and reduced ejection fraction. So this is the outcome. 1 in 5 are rehospitalized in the next 1 month, 50% in the next 1 year. And each hospitalization increases the problem. Each hospitalization begets another hospitalization. Each hospitalization increases the mortality. So at all cost, one of the most important aim of our treatment in heart failure is reduction of hospitalization. There is a major role for the mineralocorticoid receptor in heart failure. You can see the mineralocorticoid receptors lie outside the nucleus in the cytoplasm, and once the mineralocorticoids comes, it binds to the receptor, it moves into the nucleus, and there it induces changes and leads on to the development of fibrosis and hypertrophy. So it plays a key role in the development of heart failure, in the progression of heart failure, and in the complication of heart failure. So in heart failure and preserved ejection fraction of more than 40%, MR overactivation leads on to sodium fluid retention, inflammation, fibrosis, hemodynamic factors, cardiovascular hypertrophy. So it's predominantly hypertrophy, it's predominantly fibrosis, and these affects 2 major organs. One is the heart, where it leads down to cardiac remodeling, heart failure. Then it's a vicious cycle: heart failure, further remodeling, increase in heart failure, hospitalization, death. Another is the glomerular injury, fibrosis and kidney failure, and there is always a crosstalk between the heart and the kidney. So Fine Arts HF, this is the latest masterpiece for MRAs in heart failure. Finerenone, 10 milligram, 20 milligram and 40 milligram OD based on the the EGFR. Those patients with EGFR of less than 60 started on 10 milligram, moved on to the target dose of 20 milligram. Those with EGFR of more than 60 started with 20 and if possible escalated to 40 milligram. 6,000 patients, 1:1, randomized, and you can see the key inclusion criteria: 2 to 4 NYHA class, LV ejection fraction for more than 40% with a structurally abnormal heart in the last 12 months, either a chamber enlargement or a chamber hypertrophy, and diuretics in the last 30 days prior to randomization, so it's highly symptomatic patients. NT-proBNP more than 300 in sinus rhythm, NT-proBNP more than 900 in the atrial fibrillation, EGFR cutoff of 25, and acute inflammatory heart disease, CABG, stroke or TIA in the last 90 days were excluded, and systolic blood pressure of more than 160 were also excluded. They looked at the composite of cardiovascular deaths plus total heart failure events, the first event and the recurrent events, and also a composite kidney endpoint. So this is it. 20% of the participants were randomized during the worsening of heart failure event or within 7 days of a worsening heart failure event. You can see less than 7 days, it's 20.3%, 7 days to 3 months, it is 1/3, 34%, and more than 3 months, close to 50%. And the baseline treatment, it's a standard treatment, current state-of-the-art treatment. You can see majority of them, close to 90% were taking loop diuretic, means they are significant congestion remaining. Beta blockers close to 85%, RAS inhibitors almost 80%, but the use of ARNI is much less, it is less than 10%. And one of the criticism of this trial is the low use of SGLT2 inhibitors, which is the class 1 indication for heart failure with preserved ejection fraction and mildly reduced ejection fraction. It is 14%. And GLP-1 receptor analog, another agent for heart failure and preserved ejection fraction, it's close to 3%. So 2 accepted indications for heart failure with preserved ejection fraction, the utility or uptake of these 2 drugs were lower in this trial. And from day 28 onwards, there is a statistically significant divergence of the curve that's resulting in a 16% relative risk reduction over a mean period of 3 years, predominantly driven by a reduction in the heart failure hospitalization. So it was the first total heart failure hospitalizations. So you can look at it, mortality, there is no difference. No difference in the mortality, the lower graph, there is no difference in the mortality, either cardiovascular mortality or total mortality. But the difference is predominantly a reduction in the total heart failure events and total worsening of heart failure events, and a minor difference in the quality of life, the KCCQ questionnaire. This study was not adequately powered to look at the mortality, because as the ejection fraction increases, the mortality comes down. So we need a huge sample size to get a statistically significant benefit, or to evaluate as with adequate power to look at the mortality. So this sample size of this 6,000 was not sufficient. That is an Achilles heel. That's an Achilles heel for all the trials which is going to come in future also, because we need a large number. So most important endpoint that we can analyze is heart failure hospitalization. So the effects of Finerenone on the primary outcome were consistent regardless of the LV ejection fraction, whether it is more than 60%, whether it is less than 60%, because of all the older trials, including those with mineralocorticoid receptor antagonist, spironolactone, they found there was no benefit in those patients with EF more than 60%. SGLT2 inhibitors, it was only in 13.5%, but those patients who were on SGLT2 inhibitors also, there was a benefit. So it's an additional benefit. SGLT2 inhibitor do not negate the benefit of this drug. And are we paying anything? It's hyperkalemia. That's the one thing that we are worried about, and there was a withdrawal or discontinuation of 20%, that is majority of the major clinical trials. It's a standard 20% drug withdrawal. And the most important thing is the potassium. More than 5.5 millimoles per liter potassium was 14.3% versus 7%, so it is double. More than 6, it is only 3%, but no mortality associated with hyperkalemia. Hospital admission rate was much low with the use of, the hospital admission rate was less than 1% for severe hyperkalemia. And this is another combined analysis of the Fidelio DKD, Figaro DKD, and the Fine Arts HF trial. With the age, you can see closely it's 71 plus or minus 10 years. But this Figaro and Fidelio could add only 1,000 patients, because these trials were not aimed to look at people with heart failure. These are patients who gave a history of heart failure. Heart failure with reduced ejection fraction was an exclusion criteria of the Fidelio and the Figaro trial, basically in diabetic kidney disease trial. So when they looked at the combined analysis, they could find one thing. The cardiovascular death or heart failure hospitalization, there was a benefit. Death, there was no significant benefit. Heart failure hospitalization, definite. New onset atrial fibrillation, there was a benefit. And you see, these benefits were predominantly in terms of heart failure hospitalization. All-cause death also, there was no benefit. And the adverse events in the combined analysis also, 3% potassium more than 6, and hyperkalemia leading to treatment discontinuation 0.5%, leading to hospitalization 0.6%, acute kidney injury 4%, and the hormonal symptoms only 0.3%. So safe regarding the potassium also, and benefit in terms of reduction in heart failure hospitalization. So Finerenone, what is the current recommendation for heart failure and preserved ejection fraction? Where do we place it? We place it as the second pillar of therapy for heart failure and preserved ejection fraction. This could be recognized as a new pillar of treatment for patients with heart failure and ejection fraction more than 40%. First pillar, SGLT2 inhibitors. Second pillar is Finerenone. Thank you so much.
Thank you, sir, for that excellent discussion. I think HFpEF, heart failure with preserved ejection fraction, is one condition where we don't have much of options. So any new ray of hope is always welcome. The title included the heart failure with reduced ejection fraction also. So in patients, of course, you have demonstrated the excellent benefit in the preserved ejection fraction. So in a patient with heart failure with reduced ejection fraction, what are the situations, sir, where you will consider Finerenone instead of the standard spironolactone or an eplerenone?
This is only extrapolation of the data. This is not a data supported one. It's an offline off-label indication. One, patients who are likely to develop hyperkalemia, a borderline high potassium where we are worried that he may develop hyperkalemia. For example, a patient with a 5.2 potassium, and you would like to introduce a mineralocorticoid receptor antagonist, I would prefer a Finerenone rather than a spironolactone, though there is no data of Finerenone in heart failure and reduced ejection fraction. Second thing, a diabetic kidney disease patient with significant proteinuria, heart failure and reduced ejection fraction, I may go for a Finerenone rather than a spironolactone.
Sir, there is no doubt regarding the role of mineral receptor antagonist in heart failure with reduced ejection fraction. But how often you introduce this type of agents in preserved ejection fraction in your clinical practice?
How often I use it. Now the problem of Finerenone is the pocket toxicity of the drug. It's 90 rupees per tablet. So whoever who can afford and whoever comes with a worsening of heart failure in preserved ejection fraction, I would prefer to give it. But only 10% of my patients can afford it.
Jabir, what makes this Finerenone fare better than the others in HFpEF?
It's difficult to say, but maybe because of its highly selective affinity for the mineralocorticoid receptors and lack of or more safety. That may be the reason. It's a highly selective molecule and it's non-steroidal. Probably the non-steroidal molecule may have an edge over the steroidal molecule in this particular subset.
Thank you, sir, for this excellent talk, and